Good morning. Today I'm going to be presenting my paper on treatment of anisometropic amblyopia using binocular therapy versus monocular therapy. I don't have any financial disclosures. So the earlier concept of amblyopia management was that with advancing age at around 8 to 10 years, there is an end of critical period of visual plasticity. But now the newer concept is that around 8 to 10 years, there are certain stop signals that do occur, but with the right kind of treatment, by removing those stop signals, it is possible to train the brain and the eye to see better and to restore the visual plasticity. So in this regard, there is a new therapy that has recently been in serious study, and that is dichoptic therapy, wherein the dominant eye and the amblyopic eye compete with each other for attention. So the basic concept is that of interocular suppression, where there is a gating mechanism that is there from the dominant towards the amblyopic eye. So when the dominant eye is closed, as in the regular patching therapy, the amblyopic eye tends to take over and the interocular suppression ceases to exist. But the minute in a natural setting when the dominant eye is removed and the dominant eye takes over, thereby bringing in the suppression mechanism again. So what dichoptic therapy attempts to do is to simultaneously stimulate both the eyes, thereby ceasing to stimulate that particular interocular suppression pathway or that gating mechanism. So the objective of my study was to study the efficacy of dichoptic versus monocular therapy in the treatment of anisometropic amblyopia in terms of logma vision, stereopsis, contrast, and binocularity. So we included kids from 5 to 18 years and who were anisometropic amblyopia as per the EPOS guidelines with a vision of better than or equal to 6/9 and 6. We excluded kids who had eccentric fixation, any history of prior amblyopia therapy, or any other form of amblyopia. So before starting therapy, we checked their logma distance vision, near visual acuity, stereopsis through RANDOT, Worth-4 dot, and also did a contrast sensitivity. So we enrolled consecutive subjects, 15 in dichoptic, 15 in monocular. They all underwent pre-therapy evaluation, following which they underwent 10 hours of therapy over 10 days. So 1 hour a day of therapy. They were the snake game, shooting game, and a couple of other games. And then they were evaluated post-therapy after the 10 days. So the software used was the Lazy Eye Arcade, which is from the Waverly Eye Care Center in Winnipeg, California. It's a paid software. So how we actually separated them into groups was the same software game was used. For the dichoptic group, we put them on red-blue goggles. We selected the amblyopic eye, and then for the non-amblyopic eye or the dominant eye, we reduced the contrast settings to 20%. So the concept is that we reduce the contrast to the dominant eye, thereby allowing the weaker eye to see better and get stimulated. In monocular therapy, we used the same game without goggles. We patched the dominant or the non-amblyopic eye and gave 100% contrast settings to the non-amblyopic eye. So that's how we put them into two groups. So this is how the game looks. For example, this is the snake game. So the target here is going to be the left eye, which is the dominant eye for say, and right eye, if the right eye is right eye is the amblyopic eye. So this is how it would look through the red, and this is how it looked to the right. When placing both eyes, and if you put the dominant eye on 20% contrast, this is how it would look. So the dominant eye is actually much lesser than the non-dominant. This is just a short clipping of how the video game is played. So you have the red as the player and the blue as the target, and so thereby simultaneous stimulation occurs, whereas the amblyopic eye gets the higher contrast.
That
So
is with the goggle.
with the goggles, yes. So this is the pre-therapy comparison. So we had 15 subjects in both the groups. Mean age was slightly older in the dichoptic group than the monocular group. Spherical equivalent was 6.3 and 6.23. Mean axial length was 25.8 and 25. Pre-therapy 0.49 and 0.40 was the logma visual acuity, and stereo acuity was 300 and 150. Mean contrast was almost similar. So when it comes to logma visual acuity, we found that there was a good improvement in both the groups. Mean gain of letters, dichoptic therapy there were 5 letters, monocular therapy mean of 7 letters. Again, in terms of near visual acuity, dichoptic therapy 11 of them improved to N6, and in monocular 9. Mean contrast sensitivity, there was a good improvement from 1.5 to 1.9 and 1.6 to 1.95. Mean stereopsis 300 to 270, 170 to 55. So almost all were statistically not too significant. The positive predictive factors were the age, pre-therapy visual acuity, and the stereopsis. So when we look at the literature, we look other studies that have shown dichoptic therapy to be non-inferior, and that's similar to what we found, that it's non-inferior to monocular patching therapy. We found a logMAR improvement of 0.09, and this also concurred with the PEDIC study as well as the newer binocular movie therapy that is coming up recently. So to conclude, dichoptic therapy is an exciting new therapy. From what we saw, it is non-inferior to the monocular therapy. It is a good option, but it really doesn't provide a superior effect. Visual outcomes and contrast sensitivity do show improvement after 10 hours, especially for the older children. And the positive predictive factors include younger age group, pre-therapy visual acuity, and stereopsis. Thank you.
Thank you. My question is, you showed in your paper that in fact, instead of the dichoptic group, the monocular group showed better results.
Yes.
So then what is the advantage of the dichoptic therapy?
So it is, what we did see was the statistical significance was not there. So we can just say it's non-inferior. And for older age groups, if we see, we started out with older age groups for the dichoptic therapy.
But it's a paid game, na?
Yes,
you have to buy
yes,
it.
ma'am. Yes, ma'am. So from my results, I'm not saying it is a better therapy. Definitely not a better therapy to monocular. The results are good for older children. So that's
Then what is the use of your paper? If it is not superior,
you should
I
have
see no reason to present it unless it is showing a better outcome than monocular therapy. Why would someone want to go for it, pay for it, and then not have a better result?
Ma'am, I'm not saying the therapy works. I'm just presenting my results, which shows it's
Agreed,
not good. I'm
but
just presenting
the
my
results show that it doesn't.
Yes, ma'am. I'm just saying it's.
for that software.
Yes, so I cannot directly recommend. I'm just saying the results of mine
That
are not
is what-
supporting that. Yeah.
That is the conclusion I
Yes.
think we should take home.
Yes, definitely.
less cash.
And another
Dr.
point
Shruti,
I wish to make is that every patient of yours is not in a position to buy the game, you know,
Yes.
because we get patients from all strata. So, and how much does it cost, by the way? This?
The software is a paid software. One time it costs 7,000 rupees.
My
But
God.
one time you buy it, you can use it as an in-office therapy forever.
but Dr. Shruti, you said a lot of advances going on in this field
Yes.
in Western countries.
Yes, sir.
Like, so why would they do that? If your findings suggest it's not useful,
Yes, sir. So the,
monocular therapy is better. So are there any studies done in outside world where they have found specific benefit of this therapy?
almost all of the studies done so far in dichoptic specifically do not show promising results. They
So what
are
are its
non-superior.
advantage? See, if something is not working, then people are not going to explore it,
Right,
right? So why people are investing so much into this?
Why, I will tell you, sir. Now they are now coming up with movie-based therapies for this, and these have been shown to the earlier studies, and similar to this, what we have done, they are very.
So
boring
my
games.
point is, do it give any advantage? It may not be final visually, may not be right, but is it giving you any logistic advantage or therapy, or maybe parents' compliance? Is
yes,
it? Does it give you any advantage?
Right, sir. So the thing it gives us is a short-term effect, a quicker effect. That is the one thing that it gives. And second is visual attention, because patching includes a lot of compliance issues. It takes time. So
So
we are
this is
looking
what
at
I think.
alternative,
The issue of compliance may be better with
Yes,
those therapies,
yes.
and may be suited for Western people which are more educated. But in
I
Indian
would-
patient may
I
not
would
be.
disagree with that also. The compliance is not better with these games, because I have put some patients on non-paid games which were available, the tumbling blocks and all. But children get bored very easily of these games, so the attention is lost.
Probably that is the
Parents-
reason they are coming out with movies.
Yes,
Exactly,
cause-
sir.
They won't
and
get bored.
One thing I wanted to answer your question was why the Western world does it. कुछ नया करना है, कुछ तो नया करें, at least देखें. So इसीलिए
Maybe
invest
with
in it.
new technology
हाँ,
they may
just-
come out with something good.
हाँ,
So the older studies were a big failure because the games were so boring and they were so monotonous.
Yes, absolutely.
So that's why they are exploring binocular movies. Wherein the same
That-
suppression, and they have interesting studies where they've
So
compared.
your next
two
study will
movies.
be on movies, I guess.
your next paper would be on that.
Next AIOS, we can judge you again.
Yes, sir.
Chalo.